in the past, say, 15 years or so, the Israeli psychological scenery has mushroomed with an impressive exodus of people coming from all over the world to assume clinical and academic positions in Israel. Before that, Israeli clinical psychology was not very strongly represented in research. We have the honor of having Professor Gabi Scheffler here, whose research on James Mann's brief psychodynamic treatment, time-limited psychodynamic treatment, is very well known. Currently, we are adequately represented by Israeli clinical psychologists who are quite versed in various models and methods of assessment and therapeutics. And we have several of them with us, and they are going to speak on what's essential in either assessment or early detection or intervention, psychotherapy, with either or both depression and suicide. And Thomas Joyner will then discuss the various contributions. I'm going to present every speaker in turn. Who's going to go first? Joshi? Okay. Professor Josh Lifshitz, our very own. No, you said, do I? You did? Wait, David. We're okay with that? Good talk. Okay, I didn't, but I can. You don't, but you don't have to. If you want to, I can. Okay, wait a minute. Let me introduce you. Josh. Our dearest Josh, Professor Lifshitz. We snatched him from Columbia University, Department of Psychiatry. Josh is a developer, an adapter of the interpersonal psychotherapy model into anxiety disorders in general and social anxiety in particular. He's an internationally reputed researcher in the field of social anxiety and, of course, one of the leaders in IPT. Please, Josh.
So like every good talk, I'll begin with a story. When I first came to Ben-Gurion, so Golan and I decided to teach a course together in short-term therapy, interpersonal therapy, and I had been teaching the first couple classes, and then I came late to the last class, which Golan was teaching, and I walked in, and Golan, a student of one of the great personality researchers of our generation, Sid Blatt, was talking about IPT is very problematic because it needs a personality component. And how can you have a therapy that doesn't address personality features? And we didn't know each other very well at that time, so I felt a certain thwarted belongingness in my new home in Israel, and so I've been waiting for 7 years to respond to Golan. So I feel like at this symposium, it's very important for me to address interpersonal therapy. Just a few minutes about interpersonal therapy. Interpersonal therapy is a time-limited therapy which proposes that you can treat depression by improving interpersonal functioning. We address interpersonal problems, and by interpersonal problems, we don't mean the person's personality tendencies. We mean a problem in the person's interpersonal life context, which might be a role transition. The person might be recently retired. The person might have just graduated and be kind of lost, not finding direction. The person might be adjusting to an illness or another major challenge, a life stressor in the family. What we would call a role dispute, a major conflict with a major figure in the person's life, typically a family member or a spouse, a significant other. Grief, which is usually a complicated grief where the person has not succeeded in getting over a significant loss of someone, an important person in their life. And finally, a fourth category, which I think Anat might address in her talk a little bit further, but what we call role deficits, which is basically an isolativeness, absence of interpersonal contacts, interactions, important people that care about the person, lack of belongingness. And IPT addresses these problems with an exquisite and blatant disregard for personality. IPT basically takes the approach that your apparent personality factors at the time that you come in for treatment for depression are due to the depression until proven otherwise. So you come in for treatment and you have been told by people that you are dependent and needy and lazy and lack initiative and have a sense of doom and very self-critical. And we say to the person, all those things that the people have described about you, that's because you've been dealing with a very serious illness, which we call major depression, clinical depression. Now, some people may have lasting personality features which are not part of the depression. Our attitude is that we treat the depression, see what's left once the depression has lifted. Sometimes the person may have some of the same personality features, even more prominent personality features when the depression has lifted, and sometimes not. So why do we do that? Why, if personality, and as Dr. Sidney Blatt's research has shown us, personality features can moderate and predict the outcome of treatment, so why shouldn't we address personality? Why can't we segue into personality before we treat the depression? So we feel that there's certain pitfalls, certain problems to treating personality and addressing personality in someone who is depressed. First of all, it's very difficult to assess personality in someone who's suffering from a depressive episode. Maybe impossible to assess it completely and validly. Second of all, if we start emphasizing personality and what the person is about and what the person's been like and why maybe this relationship relates to certain tendencies, that the person has invited certain problematic relationships into their life over and over again, that sounds to me kind of demoralizing. And for someone who is dealing with depression and is looking for a life raft, something to hold on to and some light at the end of the tunnel, it may not be advisable to start focusing in on lasting personality features. And I was thinking during Thomas's talk and the importance of increased burdensomeness. A lot of people with depression come in feeling like they're a burden, like they're a failure, like everybody is fed up with them. And there's something that we feel for many people is very unburdening to be told that this is not you. All the things that are getting people aggravated with you and getting people, and that you feel that you're a burden to other people, that's not you being a burden, that's the depression. The depression is a burden on you, just as asthma or arthritis or another serious medical illness would be a burden on you and your whole family. And what you've taken from other people, maybe the signals that people have been giving you that they're burdened, have to do with depressive illness, and we're going to treat you and help you get over your depressive illness. So that's also perhaps a way of unburdening the person by avoiding personality, all the important things that Dr. Blatt focused on and enlightened us about, but perhaps aren't the focus of our treatment, at least. May not be helpful for everybody, but that's my response to Golan after 8 years.
As we say in the IDF, we will respond at the right time and the right place. Okay. Who's next? No, Anat. Okay, so another shining representative of the IPT clan is Dr. Anat Brunstein Klomek from the Herzliya Interdisciplinary Center in Herzliya. Anat is a clinical child psychologist. She is leading a very interesting international research focusing on bullying and suicidality in adolescents. She's also an avid suicidologist working on adapting IPT to treat suicidal adolescents, a very close friend and collaborator of mine, and thank you, Anat, for contributing to this.
Thank you, Golan. So I came in this morning thinking I was going to talk about IPT, because that's what I was asked, but just stepping up, Golan whispered in my ear, can you talk about CBT, because Eva Gilboa is not here, and since I'm a CBT supervisor, I'll switch gears and talk about a little bit about IPT and kind of continue Josh with taking it to the adolescent world, and then switch gears to CBT. And by the way, the protocols we're working on today are basically kind of a mixture between IPT and CBT and DBT, which I'll talk in a minute. So a bit about IPT in adolescents. Interpersonal psychotherapy, as Josh said, is one of the therapies for depressed adults and adolescents. And what's happened in the last couple of years is that it's been adapted to both non-suicidal self-injury, what we call NSSI, and is currently adapted by Laura Muffson, myself, and a few others to suicidal patients. Historically, suicidal patients would be excluded from interpersonal psychotherapy trials, but what we did is basically took the protocol, added bits and pieces from the CBT and DBT world, and created a protocol which includes some of the CBT components and DBT components which are used for suicide prevention in adolescents. And I'll kind of now switch gears to the CBT world. 2003, I was trained by David Brent at Pittsburgh University in the US, doing CBT for suicide prevention, what today is called CBT-SP. CBT suicide prevention, the first trial was done by the Beck Group, Greg Brown, and others, doing a lot of CBT, but what we call big C work, a lot of cognitive work with suicide prevention in adults, first published in 2005 in JAMA. And I was part of the group in the Columbia University site where we took the CBT-SP protocol from adults and we adapted it to adolescents. The unique pieces of CBT-SP, as opposed to CBT for depression, is that things were added for the purpose of suicide prevention. So these were 121 adolescents that were after a suicide attempt in the previous 90 days, and they were treated with CBT for the purpose of preventing suicide. They were all depressed, but it's a very different treatment of treating depression in order to prevent suicide versus treating with CBT for suicide prevention. What that meant, and we still use the protocol, by the way, now in Israel, in the National Suicide Prevention Program, we're training school psychologists, and not just clinical psychologists, educational psychologists, to do this program with the kids that we can work with suicide prevention, so they're not in the mental health arena in the clinics, but they're still at school, still functioning. Some of them do not have intent, but do have some suicidal ideation. And the purpose is to basically start with ingredients that include, and I think, Thomas, you had that in one of the slides, what we call safety planning, is how do we build a safety plan with these adolescents, which is built on a lot of C from the CBT, a lot of B from the CBT and DBT, and a lot of interpersonal components. So we have a full protocol for the safety planning, which is based on Barbara Stanley's and Greg Brown's work. We also do a chain analysis to understand the suicidal behavior when we then see, and I think Thomas pointed to that as well, that looks like impulsivity was basically a chain of a lot of emotions, interpersonal issues, dynamics, cognitions, if you will, behaviors that led to the suicidal, in our case, attempt or episode or ideation or non-suicidal self-injury. So it's a lot of times and oftentimes a full story. And we then go to what we call the middle phase, where we work as a skills-based intervention with teaching and practicing, by the way, a lot of work with the parents, although it's not a family-based intervention, but we bring in the parents as often as possible to work with the family on different types of skills. And I think we kind of, throughout the day, heard a few of them, like emotion regulation, like cognitive restructuring within the CBT world, like problem solving that we've heard also this morning. And I think the nice piece is about the flexibility of the protocol, which basically allows the therapist and patient to build an intervention which is tailored to the specific needs of the patient. So basically CBT-SP for different patients and for different families would look very different. They would all go through a safety planning, they would all do a chain analysis to understand the depression and suicidality, but they would then get pretty much a different treatment. So some of them will do a lot of C work, what we call big C, and some of them will do none of the C work and do a lot of emotion regulation work, learning to identify emotions, learning to regulate emotions, learning to express emotions, a lot of interpersonal or social work, learning to find where you can find support, learning to ask for support. So these are different types of skills that we kind of see them as drawers that the therapist and patient can take out of the drawer in order to work and build an intervention. And all of this is wrapped up in the last phase where we do what's called in CBT-SP a relapse prevention task. And that's where we bring in, we almost invite the suicidality piece in the room in order to see if the patient can now, with the new skills, deal with the suicidality in order to prevent future suicidal behavior. Thank you.
Wonderful. Thank you, Anat. I do regret Eva's calling sick today. Eva Gilboa-Shechtman, Professor Eva Gilboa-Shechtman from Bar Ilan University, a world leader in anxiety disorders, treatment and understanding and treatment, and a very close friend of mine. And I remember that when I came, I had a year teaching in Bar Ilan many, many years ago before I went to Yale. I took it as a mission to convince Eva there is something effective about psychodynamic therapy, and I succeeded. And that is because, as many of you know, as much as I enjoy teasing psychoanalysis, I do embrace many of the tenets of psychodynamic psychotherapy, provided that they are filtered through empirical research and that they are open to embracing other interventions, what we call these days integrative psychotherapy, which brings us to the next speaker, Dr. Sharon-Ziv-Beiman. Sharon, everybody knows Sharon, an ultimate leader in the psychological scenery, a very central person within relational psychoanalysis or relational psychoanalytic psychotherapy, the director of various clinics and psychological services companies and group practices. Also, an upcoming researcher, and in her research, she examines the effect of therapeutic self-disclosure, both experimentally and clinically. Sharon will speak about depression from an integrative point of view. You see it? Yeah.
So I'll do my best efforts. I'll do my best efforts to represent the integrative movement or the call for integration in psychotherapy. I believe from my clinical and research experience that integration has a lot to say about treating depression, especially resistant depression. And when Golan wrote us and asked us to present what is essential from our point of view about treating depression, the metaphor that was raised in my mind, and it's good that all of us are after lunch, and I hope that you are not hungry, was a metaphor of a cooking stove. And the cooking stove I imagined was a big cooking stove with big pots, with a lot of food inside, spicy food, a lot of different kinds of food, vegetables, pasta, meat, a lot of, the need is for different kinds of foods. And what you don't see in the photo, because I didn't find the photo with the cookers, and the cookers are, of course, the therapist and the patient. Now, I will try to use this metaphor to illustrate or to portray two different or two dimensions of the cooking process of treating depression. The idea is that we have to create a full meal. We can't just offer first course or main course or dessert. We need to cook a full meal. And the two dimensions I would like to portray, the first one is the variety of hot dishes we are offering, and the second is the cooking style. So I'll start with the hot dishes. The first step is to create together with the patient explicit co-constructed schemes or narratives that explain the depression. I think almost any therapeutic approach has their own way to create those schemes or narratives. Schema therapy, I'm looking at Eshkol, CBT, IPT, of course, dynamic, behavioral, existential. Every method has its way to create the narratives. The next step is to create defined and agreed upon combination of behavioral, experiential, cognitive, functional, and interpersonal goals. And the emphasis is that we need a combination of goals. When you're treating a persistent depression, especially with suicidal patients, you cannot, I find it that it's not enough to use one approach, one course. You need few channels to work through, and the goals, as I perceive it, should be defined through few channels. And then the next step is to use active intervention that address those goals. What I find is that it's essential that at least one of the goals will be to create meaning. What I'll try to exemplify with the cooking style elements is that all these elements, the narratives, the goals, the interventions, all should be cooked in a very intensive style that involve subjectively engaged and active therapist. And when I mean subjectively involved, I mean that I take it very personal that someone will get out of his depression. I'm not just a therapist, it's my personal business. I'm also feel that it's to be or not to be issue for me if you'll get out of it. The second element of this intensive cooking style is a simultaneous and dialectic movement between two movements. One is empathic acceptance of the distress, and the second, which is very different, is determined attitudes towards change. So as we grow up children, we have to hug and to push. So when treating depression, you have to understand and to fight with the depression. And sometimes you need to do it one sentence to accept and the other sentence to fight with the depression. And this dialectic moves the combinations of the two polarities of acceptance and of determinism to get out of the depression is what creates an opportunity for change. Another aspect of this sweating cooking style is intensive and, if necessary, very rapid shifts between working on different goals in the same sessions. I have like a small argument with Golan. If we have to cook all the meals together, my attitude is that I'm doing the rice, I'm going to the meat, then I'm going to the vegetables, again to the rice. I'm switching very rapidly between goals, schemas, interventions. The patient cannot rest. I would like to believe that maybe this cooking style can penetrate these fearless faces or this dissociated states where there is no desire to live. So I try to penetrate it with very rapid shifts. I can do, when I'm in integration, I can address goals from different therapeutic approaches in the same session. And other aspect of it is the focus on metacognitive conceptualizations of the goals and relevant interventions in the beginning, middle, and towards the end of the meeting, meaning I'm drilling what we are doing, on what we are working, on what did we work last meeting, on what we are going to work today, in the middle, what happened until now in the meeting, in the end, what didn't happen, what will happen. It is very intense work, and there is a strong emphasis on collecting ongoing feedback from the patients. There is a lot of new literature about the importance of collecting feedback, which deserve a symposium by itself. But I believe that these principles that I portrayed just now are echoing the forefront of treating depression, which means, as Anat offered, tailorized or personalized integrative treatments. The Society for Clinical Psychology identified by 2014 12 psychological treatments for depression that meet EST criteria. And Harris et al. At a paper from 2015, very fresh, tried to guide us how to choose, and they offer 3 ways. The first way is the psychotherapist competence. So the patient will be dependent on which approach can be best practiced by the psychotherapist. The second way is to select one treatment from the 12. And the third is selecting active ingredients from more than one treatment. Harris is doing a lot of work on it, and in a way that is very similar to the principle from my kitchen. They are offering a very structural model, multi-theoretical psychotherapy for depression. There are 4 stages. The assessment is the first, and they give very strict or very clear symptoms that they are checking: dysfunctional thoughts, ineffective actions, maladaptive feelings, distorted interpersonal problems, and psychiatric symptoms, which represent all the approaches. And then they are trying to establish one or more focal dimensions, to formulate a multi-theoretical conceptualization, and to choose interventions from catalog of key strategies. And they have a catalog, it's a real catalog, and they have guidelines how to choose. Very similar, Cooper et al. Are offering the pluralistic treatment for depression. I will not read all of it, but it's very similar, and they are doing now clinical research about it. And their emphasis too is on tailoring. And the tailoring is made by formal feedback and through dialogue or meta-therapeutic dialogue with the patients, and they try to build for each patient the best treatment. And they also have, it's not like, generally speaking, choose from, they are offering intervention to cook from. But I have to represent also the relational approach. What we find missing in the current integrative models is that the relational aspect, to my best understanding, is not well enough represented. There is insufficient attention to the therapeutic relationship, and from a relational point of view, there is not enough place for the idea that the therapeutic relationship is by itself an arena for creating therapeutic change, which is the main idea of the relational premise, which means that we are not dealing with the relationship just as a way of helping the other interventions to work better, or when we are using interpersonal interventions, or when we identify the depression through interpersonal difficulties. We believe that the interpersonal relationship with the therapist represent the main arena of change. And if things are happening in the relational space, which is created in therapy, this is a key factor for change. With a strong determination to include this aspect in future models, Golan and I are working now on a model which is called TRINT. Now Freud is here because the narrative went out of the title. It should be relational, integrative, narrative treatment for resistant depression. And as expected, there are two main dimensions. I will go over them very briefly. The first one is characteristic of the therapeutic alliance, which is characterized by a strong emphasis on therapists and presentation, including emphasis on mutual impact, engagement, therapist self-disclosure, active stance of striving towards change on behalf of the therapist, high intensity of connectedness and accessibility, emails and SMS between sessions if needed. Mindfulness and relaxation techniques are used if needed, and the model has stages, I would say positions. Golan says stages, we'll fight and Golan will win, and there will be stages. The first one is assessment as needed, and then psychoeducation about chronic depression. Then the therapy is getting into multiple selves analysis or personal project analysis based on the psychodynamic idea of Bromberg's, Mitchell, and other of viewing the self as multiple, and the techniques are taken from variety of approaches, and the purpose is to create a dialogue between different self-states of the patients, the depressed, the self-criticizing self-state, as well as healthy, positive, creative self-states, and to learn the relationship between them. The idea is that the depressive or the self-criticizing self will stay there. We cannot request him to step out of the room, but we can open a discussion between several self-states and not give him to rule or to lead the personal experiences. Then we invite the patient to behave future plans of non-depressive selves through behavioral activation and their reflection. We activate the positive or the healthy self-states of the patient with strong emphasis on seeing the future or being able to imagine the future. There is this next stage or emphasis is on interpersonal inquiry using IPT techniques, including role plays, plus ongoing behavioral analysis and cognitive structuring techniques. Also here, we continue with the behavioral analysis, and as I offered in the beginning, there is strong emphasis on structuring metacognitive interventions. And the final step is working towards creating representational amalgamation which means to consolidate a complex, curative self-narrative that relates to the matrix of the multiple selves, multiple others, and their relationship. To be continued.
I don't know, does anybody know how I can stumble upon $20 million to test this model? But let me tell you, one of the things I really liked about Thomas's mesmerizing talk today was that he used the word fight, fighting the fight, fighting over people who are suicidal, fighting over people who are depressed. It was, I mean, nobody can take from Freud the monumental historical achievement of coming up with the with the talking cure, but it was the same Freud who made, in my opinion, a staggering mistake of cautioning us against what he called the fury to heal. And I believe that especially with chronic and suicidal manifestations of depression, in order to get to the person, in order to entice the person in any form of intervention, be it interpersonal or behavioral or anything, you have to show this person that you deeply care, that you are going out of your way, that it's personal for you that he or she will recover. And so I believe that coming from various points of view, definitely the relational, but also the humanistic existential, and the cognitive behavioral, collaborative empiricism, people are beginning to renounce the relatively anonymous model of the therapist and encourage an involved therapist with a fury to heal. Oftentimes you can't do that alone. You need some allies. I have one such ally, a psychiatrist named Hadar Shalev. Together, we furiously trying to work with some very depressed and suicidal young people. Hadar is also a magnificent thinker, thinks outside the box. I can give you one of the highest compliments that I can give by labeling you as a humanistic psychiatrist, and who's also very strongly versed in pharmacology. And he's going to be very provocative today, speaking about euthanasia in the context of depression. Okay, go for it. It's here.
Thank you for the invitation. I want to begin by apologizing for my English. It's based mainly on movies. And since the kind of movies that I watch are not really Oscar awarded, my vocabulary is not really impressive. Okay. And I really want to ask a question. And the question is that, should we accept suicide requests of depressed patients? And it's not a question out of nowhere. During the last year, I've had five patients that actually asked me to fill forms for them in order to apply the forms in Belgium or the Netherlands and ask for euthanasia or assisted suicide. These two terms are quite similar in meaning that the patients are willingly, intentionally ending their lives. The only difference is that in euthanasia, the physician is actively injecting something or giving the patient a medicine, and in assisted suicide, you just put it beside him and he decides when and where to take it. So I've had patients asking me to fill forms for them in order to recognize them or to give them the validation that they have treatment-resistant disease. One of them was schizoaffective patient, and all other four were depressed patients. And I'm asking whether we should apply. So I'm not the only one that asks. Actually, in Europe, in Belgium, and in the Netherlands, it's already legalized to have patients have euthanasia. And also, by the end of 2011, in Belgium, they had their first 100 psychiatric patients that appealed, that requested assisted suicide or euthanasia, and they published it during last May in BMJ. And we're going to go over it for a minute. The main argument that they had in favor of providing life-ending assistance to psychiatric patients is that their suffering can be equally unbearable as the somatic suffering of other patients. And of course, they're right. We all know mental pain is not less painful than physical pain. And of course, we are today, nowadays, we accept euthanasia or assisted suicide with cancer patients that are considered to be non-curable or terminal patients, and not only with cancer, but with many other diseases. Now it's okay to allow assisted suicide. So what's the difference? Why not to allow euthanasia or assisted suicide for patients that are willingly want to die? For sure, if we see their illness as terminal, as drug-resistant or treatment-resistant. Yet, the main argument against providing such assistance is that suicide prevention is a primary purpose of psychiatric care, and the key focus on training for psychiatrists, and not only psychiatrists. Look or listen what everybody said here today. We all aim our efforts in order to reduce suicidality and to prevent death of our patients, whether by suicide or other means. So, should we? In Belgium, they did. So here are the results of what they've published. And you can see that the first 100 patients, psychiatric patients, only psychiatric patients, that applied for in request for euthanasia, mostly were women and were female. And you can see that most of them, where's the... Okay, and you can see that most of the applicants were by patients between the ages of 30 to 60, okay? And that's not all. This one? No, wait. Oh, it's not, okay. Okay. Most of the patients suffered from a treatment-resistant mood disorder. 58 out of the 100 had a mood disorder, and what they've published is that 48 of them were with major depressive disorder and 10 with bipolar disorder. I kind of think that all of these 100 had depressive disorder. Maybe not as their first main illness or disorder, but I guess they were depressed during most of the time, and I guess during the time they applied for euthanasia. 29 patients had comorbidity with personality disorder, mostly borderline personality, but not only. 3 of them had dependent personality, 2 were antisocial personality disorder, and so on. But most of them were borderline personality. In all patients, the suffering was chronic, constant, and unbearable, without prospect of improvement due to treatment resistant. And the term treatment resistant means that physicians or the therapists can't actually promise patients to have a prospect of improvement in a reasonable period of time. I mean, it's not enough to tell the patients it's going to be okay. We have to say when it's going to be okay. For how long should I suffer, or I'm going to suffer before it's going to be okay? And maybe I'm not willing to suffer so long. Maybe I want to die before that. 48 of the 100 patients' euthanasia requests were accepted. 48% were accepted. Euthanasia was performed in 35 patients, which are almost 73%. 2 patients committed suicide before the procedure. They didn't even wait. And 11 patients decided to either postpone or cancel the euthanasia procedure. What they've said during follow-up or phone conversations was, knowing they had the option to proceed with euthanasia gave them sufficient peace of mind to continue their lives. And that raises a question. So what if we did accept the request and we went on with euthanasia, and we know now that some of the patients are not really going to do that? Okay, maybe they're going to postpone. Maybe if I waited one more day, they would say, oh, you know what, let's wait. Now what? And still, it's a question. It's a question, and we're usually, as therapists, we're trying not to deal with it. And if we're not going to find the answer for this question, where's the line? Where's the line that above it I'm going to accept that my patients are willingly want to die? The patients are going to decide where that line is. So maybe we should think of it before that. And why? Why do depressed patients actually want to die? That's a question. I mean, maybe we're not thinking enough about a major depressive disorder as a chronic disease. I want to show you that, and I'm sorry, I like the term, it's a busy slide. I didn't know it before. But look, this is from a work of Conradi. It will be easier to see it here. It's the same results. Conradi followed about 150 depressed patients, outpatients, for 3 years, and he measured their symptoms every 3 months. And you can see that the prevalence of depressive symptoms continues well into periods of remission. So even when we say that our depressed patient is now in remission, it means that they no longer have enough criteria in order to fulfill the description of depression, of depressive episode, major depressive episode. But look, okay, the orange one is during remission. And during remission still, about 20% of patients have depressed mood. Over 40% have cognitive problems, lack of energy, sleeping problems, worthlessness and guilt. And death and annihilation is not so prevalent. It's not as prevalent as other symptoms, yet this is the solution many times for patients. And I think that we're not pushing enough to treat our depressed patients during remission. Now is the time to actually give them the treatment. Psychotherapy should be given during remission and not during the major depressive episode when patients have really bad cognitive problems. Over 90% of them have cognitive problems, and it's hard to actually have psychotherapy work with them. And by the time they end their depressive episode, we feel like it's all over now, and we discharge them, and then we know paradoxical suicide, we know the wave of suicidality that becomes usually around 6 weeks after discharge from wards, from psychiatric departments, and so on. So at the end of my short presentation, I'm repeating the question: should we accept suicide requests of depressed patients? And if so, when? I know my answer, but I'm willing to give it, but my answer, we shouldn't. I think we shouldn't. I think we don't have enough. Today, according to what we know, we can't allow giving up patients. And I'll tell you why. I have many patients that are living happily, working, having relationships, and so on. And I'm sure that at some point, I thought they are treatment-resistant patients, and seems like they're not. And of course, I have many patients that continue to suffer, and I'm helpless as they are. But where's the line? I mean, only after deep brain stimulation? Is it enough after ECT? Maybe only after 2 treatments, 2 medications from different classes, which is the European guidelines. They said if you had enough experience, or if you tried more than 2 medications from 2 different families of medications, it's enough to announce that the patient is treatment resistant. I don't agree, but I'm asking. Thank you.
Thanks, Hadar, for the thought-provoking talk and the fine English. And Hadar brought to the fore what we already know, that depression can and usually is very chronic. And the question is, how can we prevent depression from having a chronic course, especially in late adolescence and young adulthood, where suicide is becoming one of the leading, if not the leading cause of death in those ages. Perhaps this is the time to detect it and prevent it before it becomes chronic. A person that focuses on multiple clinical factors and processes and conditions in this age group is Professor Danny Koren from Haifa University. He is particularly known for his research on early detection of psychosis, but will speak today also about early detection of suicide.
Hi, everybody. So you thought you've heard funny English? Wait for the next presentation. My ideas are even funnier than my accent. So originally I thought I intended to talk about suicide and psychosis, especially or particularly because of an interesting phenomena that we see in the clinic and which is well documented in the literature. And the phenomena is that we see a lot of suicidal thoughts and intentions before and after first episode, or before and after psychotic episodes. But we usually do not see suicide attempts or suicidal thoughts during first episodes or at the peak of psychosis. And that's quite fascinating in my mind. Is it a defense? Is psychosis a defense against suicide? The way I've heard once a patient say, had I not become psychotic, I would have probably killed myself. So losing one's mind versus losing one's life. Or is it that they are not organized enough and focused to do that? I'm not sure, but that's an interesting phenomena. But I decided not to, I figured out it would be too difficult for me to squeeze it into 5 or 10 minutes. So I decided to talk about, for sake of refreshment and minimizing interference, to talk about something which is completely different and perhaps lighter. And where is the, how do I go from here? Page up. Do you know how do I go up? And that's about detection and monitoring mood, depression, and mania, and suicidality using social media and smartphones. And more specifically, I mean, this is a paper that was published 2 years ago by people from Microsoft. And what they tried to do is to use Twitter in order to develop a prediction model for depression. And now they're working on suicide using Twitter. Now they're working on using Google searches and stuff like that. And there are some fascinating breakthroughs in that area. Whoever thinks that we have privacy, and if our records at the clinic would not be disclosed, nobody would know about our mental condition, that's an illusion. I can assure you that. It takes 2 or 3 Google searches about antidepressive or antidepressant medications for everybody to know that we are probably depressed or suicidal. And what I want to show you briefly, how do I? I need some help here. Reached the end of the presentation. great.
slide.
Wait. Here. Probably. So this is a new startup that is being developed at the University of Tel Aviv by people from the biophysics engineering department. They gave me permission to present it, but I have to say I have no vested interest, I have no stocks in it. They approached me, they tried to get me to collaborate with them to see if it has any potential for early detection of psychotic breakdowns among adolescents, depression, suicide. And I want to show you because I believe we're going in that direction of seeing more and more monitoring, even treatment via social media and smartphone. So LifeGraph is a smartphone-based system for monitoring behavior of patients, of adolescents. And what they do, they basically collect data that the smartphone record constantly, all the time, about the acceleration, about movement, about screen on off, device on off, charging, calls log, text logs, data amount. And I'm not talking about content, just it's completely content free. They have the capabilities, technologically wise, they have the capability to collect data about the content of the text and the calls. They do not get into that for all sorts of ethical reasons. But I want to show you what they can do without that. And this is results from 3 sites study that they did recently, completed recently. And this graph, this figure, shows the activity of one healthy comparison participant. What you see at the x-axis are 3 months, are days, basically, and the y-axis is the hours a day. It starts noontime, midnight, noon, and then begins another day. And what we see here is the activity collected from the iPhone, movement, calls, text, all sorts of activities. And what we see here is a patient or participant what you can see is that there is a very clear differentiation between wakefulness and sleep. You can see the dark area is nighttime. This patient is active during the day and rests during night. Now here's another one. I deliberately hid the diagnosis of the patient. Now, do you have any guesses regarding this patient? What would you say this patient is? According to the amount of activity, according to the pattern of sleep, wake, does he sleep well? No. Is he active during the day? Not so much. Are there any differences? So, for lack of time, this is a unipolar disorder patient with mild depression. What you can see, the mild depression is the pink window at the end. You can see that compared to his own baseline, it becomes even more depressed in terms of level of activity and stuff like that. Now there's another one. What we can say about this patient? First of all, can you see that this patient, it's actually a female patient, is a religious, observant patient. How can we tell that? By the clean, you see that every Saturday, every 7 days, there is a clean line. The telephone is shut off, the smartphone is shut off. And then there is a holiday, Purim holiday towards the end, so there are 2 days in a row. So this is an observant. Another thing we can see that this patient wakes up using an alarm clock. You see the time, her pattern of waking up in the morning is kind of similar. She wakes up using an alarm clock. And what would be her diagnosis? Any guesses? By the amount of activity. This is a This is a bipolar disorder in remission. That's another bipolar. But the interesting thing here is that we can see the period before deterioration that led to forced hospitalization. So you can see that this patient begins being depressed, and then she becomes active, agitated. We see that her pattern of sleep, almost no sleep, and that's something they see from the smartphone. That's the same patient. That's the kind of feedback that either the treating clinician or the patient herself or a family can get from the application. They download the application, and the application gives them feedback and gives the treating clinician feedback regarding their mental state. And these red flags tell the patient and the clinician, and from their experience they say that actually it has a therapeutic, this kind of monitoring has a therapeutic effect for patients. They feel that they are better monitored, held, and contained. And just want to conclude with something about treatment. The next 10, 15 slides. Just kidding. It's the only one or the next one. Well, I can't speak about, I don't have fully developed model for treating depression, but something which I found that usually works in my own work is what I call a short-term flight course for angels, or, nothing works without an acronym, so STF, CRA, or you can pronounce it Steph Curry if you wish, and this will give you an insight into my infantile, premature admiration for basketball players. So what's the Steph Curry treatment? And it is based on G.K. Chesterton's brilliant insight regarding the reasons. He was asked, how come angels can fly? Now, do you know the answers to that? Anybody know the answer to that? Because they take themselves lightly. So next time you have a patient or a friend or someone with who's very high on self-criticism, try that. It usually works. Obviously, two other things that are very important is, first is that somehow patients need to feel or need to know that the treatment, our motivation for working with them is not only altruistic in nature. It's not only about helping them, but it's also about helping us, society, because they are valuable. We have something to benefit from them, and this goes or taps into perceived burdensomeness. And also they need to somehow get the sense that they're attacking themselves. It's not just a business of themselves, their own business, but they have a business with us too, because they attack someone who is important for us, whom we respect, whom we believe is, whom sometimes we have fondness for. So that's something, it goes into the thwarted belongingness. So thanks. Hope I didn't get too much.
And now, of course, Thomas will gather it all, integrate it, and push the envelope further.
Hello again. Been a long day, so I'll try to get right to the point, or a couple points quickly. There's a psychiatrist in the United States. He told me this story once about how he talks to his suicidal patients. And he says, this is what he tells them. I'm not necessarily recommending this. This guy can get away with it because of who he is, but it's interesting what he says. He tells his patients, if you kill yourself, I'm going to track you down, even if I have to go into the bowels of hell, and I'll pull you out of there and I'll hold you accountable. He says that to him. And I don't recommend that necessarily, but it gives you a sense of the kind of caring power that can convey about how much he cares about it. And I agree with that. I think that kind of makes a difference. I like the IPT, Joshua talked about that, Anat talked about it too. That insight that they really, just insist on. This is not just an illness. This is a major illness that we're talking about here, and it changes everything. There's just so much wisdom in that, and I'm really completely on board with it, and just think it's an important thing. It's my opinion that of the people who kill themselves, 100% have a mental disorder. There really isn't any controversy about the figure of 90%. That's a wide consensus about 90. The controversy is it 90, is it 92, is it 95, or is it 100? My view is it's 100. And I think that's kind of a compatible view to a lot of the views in psychiatry and aspects of clinical psychology, not all of it. I agree that it's arguable, but that's my own view of it. Anat talked about safety plan. I just wanted to reiterate how important that is. We do it very routinely, even for pretty low-risk patients. Including reasons for living is a big part of our safety planning. We have hope boxes, virtual hope boxes for them that we put on their phones. And a huge part of it is means restriction, or what we've started to call means safety, because I'm from the southern United States, and if you tell somebody in the southern United States that you want to restrict their guns, doesn't go well. But if you say, I want to be safe about your guns, better conversation. The cooking style analogy is a great one. I really enjoyed that. The one analogy that I've used is kind of similar as a pilot. We have a fighter pilot here who can tell me if this has any accuracy, but this is a helpful image for some trainees to get in their head about working with suicidal patients. You're flying a plane and you got 2 dials to keep track of. And your head's got to be on a swivel like this. You can't lose track of either one. You always got to have them both in your visual field, but you only have one visual field, so it's got to be like this. One is the suicide risk. If that spikes, you got to turn to it and handle it, mitigate it. The other is the treatment of the mental disorder, however it is that you're doing that. And so that's how it is for me working with suicidal patients, is you're like this. And if this is okay, if it's managed, the suicide risk managed, I'm treating the condition, whatever that is. For me, it's behavioral therapy for whatever that is, for me personally. But it doesn't have to be that. It could be whatever. But then I'm looking back at that dial, and if it spikes, forget about that. Got to mitigate that risk, get it to where they're not going to die. Then I turn back to that other dial. Similar to the cooking style kind of thing, looking at different ingredients, different pots. Story Dr. Shalev reminded me of. You got a guy, 35 years of age, paraplegic, very depressed, deeply depressed, suffering in great agony, both physical and mental. Turns to his wife and begs her to turn off his breathing apparatus so that he can die and end his suffering. He can't do it himself. Begs her, and she refuses. At that moment, he definitely wanted to die. He was just 100% sure of it. She refused. That dude's name is Stephen Hawking. And he just recently, again, said how much in favor he is of physician-assisted suicide. And if I had a chance to talk to him, I'd say, who's right, you in 1985 or you today? I don't know about this physician-assisted suicide stuff. I'm with Dr. Shalev. That's a scary thing to start to get into. But it's an interesting one and a controversial one. Stephen Hawking had his way. He'd be dead, and we wouldn't know who he is. We would never have read A Brief History of Time. He wouldn't have solved all those things that he went on to solve. And then, let's see, sorry. Oh, the tweet, the Twitter, and the things that Danny talked about. That's the future. That stuff is amazing. I wish I knew more about it personally, but my students do, and it's that's going to be just so promising. And the thing I like about it, I like a lot of things about it, but one is you got a personal baseline on somebody, and then you can see that change from the baseline. We do that in our clinic, much lower technology, just on a 1 to 10 intent rating. Sometimes a student will call me up, my patient's got an 8. Probably we should send her to the hospital, right? Another student calls up, 7. He's fine. Not an 8, not a 9, not a 10. The one who had an 8, I said to the student, what was it yesterday? Oh, it was 8. What was it the day before? 8. Day before that, 8, 8, 8. She's not going to the hospital. She's stable. She's got problems, but it's not spiked like that. The one who had a 7, what was it yesterday? 1. Day before that, 0, 0, 0. He might have to go to the hospital because that change from baseline. We're getting at low tech. What Danny's talking about is high tech and is the future. With that, I'm going to close. This has been a lot of fun, and thank you, Golan, for putting it all together.
Okay, let me just briefly say 3 things. First, thank you so much, Thomas, for coming and educating us. Second, you have been a marvelous audience. Thank you. And third, it's time to take off the tie. Bye-bye.